neuroscience and brain physiology can help us to change orofacial praxis. The learning objective of this presentation is to introduce the different ways to rehabilitate swallowing, to discover a new unconscious, or anoetic is the good word, re-education in order to restore nasal breathing and a myofunctional balance. To understand the physiological and the biochemical modification happening in the brain, and at least to be able to use this method for your patients. Praxis are defined as the ability of a subject to coordinate a movement in order to make it meaningful and effective. They are managed by a neural network, which are a set of neurons connected at the synapse and where alternating electrical and biochemical processes from the originating neuron through intermediate neuron. Intermediate neuron can be from 3 or 4 to millions of synapses. The message is sent from the first one to the last destination neuron. I think it's very important to understand how all these things happened. And I like very much this sentence from Marguerite Yourcenar, which says, finding the secret of a string under the stones. And too many practitioners look the stones, but not look to the behind the sources. I might give you some prolegomen, which is a kind of introduction to explain how the physiology can drive an amorphic growth of maxillofacial area. Sucking swallowing is the first practice and it will be the physiological method to swallow in the early child. And this practice has been developed in utero in the brain stem. It will be physiological from the birth to the apparition of a mastication. And we must know that the fetus was in a liquid environment at a constant temperature and continuously fed. And when births appear, he will have to breathe for the first time, just after a physical challenge of going out, and moreover, without being fed anymore. The swallowing program is from paleocortical origin, and we remain physiologically as long as the mouth has no teeth. The tongue completely fills the buccal cavities and established a contact between its lateral part and the cheeks, and essentially between the anterior part and the labial mucous membrane. The seal that suctions required is realized by the contraction of the lips, and this action is controlled by the facial nerves. When the baby swallows, the mandible is stabilized by the contraction of the facial muscle, while the tongue is inserted between the alveolar ridge and rests forward on the labial sphincter. And we must not forget, because we are speaking about baby swallowing, but 33% of adults has still a dysfunctional swallow. It will be followed by the secondary orality from the second postnatal semester, and from reflex it will become praxis. The neurological commands and neurological centers are different. And we must know that the information are constantly analyzed and generally ignored very quickly, but it can lead to a reorganization by anoetic way if it is relevant. The mandibular gesture of mastication implies a slow neurological organization and maturation whose centers are in the frontal cortex of the brain and whose control is ensured on one hand by the geniculate bundle, which is depending from the pyramidal pathways, and on other hand by the efficiency of the nerves of the brain stem. The child will spontaneously discover the need of an upper and posterior position of the lingual dome, which is created by the tension, the action of a styloglottis muscle. And this muscle also reduces the width of the tongue and enable the lingual tip to be in a physiological area without any sensorial references. And we will get a posteriorization of the initial motor image growing from the exophase to the endophase. The mastication in temporary teeth will only be really efficient at the age of 4. And this acquisition will activate neurogenesis, and 60% of the children will naturally modify the program that manages swallowing. When this work is done naturally, there is new synapses we are created that will create new circuits, and the new sensory information will go to the sensory motors area by a bottom-up ways and constitute a new neuronal network. This research has been done by Eric Kandel, who was a Nobel Prize in 2000. And by the muscular forces it will generate, we will have an optimal growth of the jaw. And we must not forget that when we see children, one children about 2 have a good occlusion without any intervention, and we think all children have a problem, but we only see children in our offices which will need a problem. And so it's very important to know that 50% of children will never need an orthodontic treatment. And the control is done by the trigeminal nerve, which is activated during this stage, and it will take place instead of a facial nerve control and will inhibit its action. The trigeminal nerves, which also control breathing centers in the pointing tegmentum by its sensory nucleus, will favor nasal respiration and allowing the tongue to have a high posture in its posterior part against the roof of the mouth, and so the seal will not be labial but lingual. And this double function necessitates for the tongue to be in a posterior and occlusal position. Professor Deller said it's too often forgotten by re-education of orofacial function, and it's quite likely one of the causes of a too frequent failure of re-education. And this potential for changing behavior, include this one, comes from the brain, and it's controlled by genetic. However, endogenous or innate factor only produce possibilities. And we must know that neurons are not enslaved by its gene. Changeux, 20 years ago, says that the genes will not be expressed unless the adequate exogenous conditions arise at the right time. We can say more, and that the genes are activated or deactivated by our belief, our emotion, our attitudes. And to give a representation of this difference between genetic and epigenetic possibilities is to take Fifth Symphony of Beethoven, when you have a transcription of what he writes. But that's genetic information. But if you will give to 5 different orchestra this in genetic information, you will have 5 different symphonies. And that's we call the endogenous influence. There is 3 main causes from the maintenance of sucking and swallowing. Because the child has never had the opportunity to discover this new mode of functioning. Why? Because nutriment are not the same, has evaluated and don't stimulate mastication. And sometimes the child has discovered, but the limbic system, mandatory, says, oh, yes, it's interesting, this new program, but I don't need it. And I like to be like a baby. I like to have thumb sucking, to have my pacifier, to be fooding by a bottle. And the last thing, which is also more important, is that the anatomical environment is already not too deformed to allow this new program. And when I say 50% of the children are concerned by influence of this normal changing. And it will be in this sample that we will meet children who don't need orthodontic treatment because dysfunction will lead to dysmorphosis. So, what are the solutions for the orthodontic practitioner? One of the main solutions used by a lot of practitioners is waiting and hoping that the normalization of the dental arches through the orthodontic treatment would lead to a spontaneous modification of the function, also by a bottom-up pathways, and it sometimes be a good solution, but it's like to play a casino. if you don't take care. Maybe this approach is efficient, but maybe it will not be efficient. The second solution are the trainers. The trainers have been imagined by Farrell in Australia and by Bergensen in the United States. It's an appliance which a lot of practitioners use it, but it's it's not easy to make the patient wearing that appliance for 2 hours per day and all night long. To wear this appliance during night is not useful because you cannot learn while sleeping. Druckmann and Bjorks have discovered that the time of encoding is diurnal, but it's necessary for the consolidation to be effective that the information is transferred to other brain area during sleep. And the MRIs have revealed that there is an electrical reactivation during sleep as the brain will replaying the activated neuronal sequences that had been printed in the days. The third one is to ask therapists, and generally it's a speech therapist, and they will set up a strategy, this time by a cortical way to enable this imprinting. And the patient becomes aware of the gesture that he usually carries out, and then of a gesture that he must carry out until repetition enable this action to be automatic. And Eric Kandel, again, has discovered when you use this wave, top-down pathways, the result is an increase of the neurotransmitters in the synapse, but slight stimulation realizes only synaptic transmission, and the nucleus is not involved. And we are in a short time memory. If there are repeated stimulation in a short amount of time, a dialogue will be created between the synapses and the nucleus in order to activate the Krebs and produce a new protein necessary for shifting from the short time memory to the long time memory. And this new protein is CPBE, which will come after the glutamate, and it will be considered as a prion. In other words, it will ensure the permanent transmission of the message. And to integrate the long time memory, we need this repetition stimulation. And if you go to the speech therapist once a week, and if you don't do the exercise, all you have printed days will be lost next week. So it's very important when you use this top-down way to be very attentive to do the exercise at home. But there is another way to stimulate long-time memory, which is a biochemical way. And Mark Goff and Mark Inter has discovered that a highly emotional moment can bypass the normal constraints and produce enough MAP kinase, the same MAP kinase molecule by inactivated CREB2 and stimulated CREB1 to directly store this experience in the long-time memory. And remember, if you had a car crash 20 years ago, you will always remember that it was for a Christmas night. You are driving to go to your parents with your wife, your children, and you don't need to repeat during 1 month or 2 months the condition of this car crash, because the emotion produces enough MAP kinase that all the information are printed directly, immediately, and sent to the long-time memory. And our strategy is to use the deconnection of the synapse between the tongue and the lips. The major effect will be caused by the inability to swallow saliva as usual. And indeed, as the child can no longer extend his lips, he will be unable to answer the seal at the labial level, which is essential for the development of a motor program of sucking swallowing. And you will have an intense and brutal and immediate reaction at the level of a brainstem. I must find a new program very quickly. So I will present you froggy mouth, because all this information about neuroscience can explain the efficiency of froggy mouth. And froggy mouth is a device which is only worn 15 minutes a day, and during a short period of time. And the patient will be in front of a TV, because looking the TV is a reward for the children, and the limbic system like rewards. And that will force the child to discover a new way of swallowing, but it will be with a non-conscious ways. And as Mazot and Pouet says, the child is confronted with a contradiction. First, an impossibility, a question that forces him to question and reorganize his previous naive or incomplete knowledge. I just want to show you the first child we have were froggy mouth, and he comes from a neurological department. He can't swallow correctly. He has a wrong ways. He is MCAs and very handicapped. And you can see when we put the froggy mouth, the emotion is his eyes, and it's quite impossible to re-educate such a child with traditional speech therapy protocol. And we can see 2 weeks later, when we can see how his face has changed. You can see the eyes are not the same. And look, he have understanding in his low brain how to swallow correctly is saliva. The most difficult thing for the parents was to take it off 15 minutes after I've putting the appliance, because the child says, "Oh, I am so comfortable, I don't want to take it, you take it off." So the froggy mouth activation of an emotional system, and so the resulting of this stress opens up a new mode of immediate recording in the long-term memory. And the researchers call them a now print. That means printing the current contents of the neuronal activity into memory. And the new program will immediately become part of the implicit memory, a memory that does not refer to any previous learning. It does not require repetition to be retained, and recall does not require conscientiously attention. We must note that the implicit memories are stored in the cerebellum and the amygdala. The stress facilitates learning, and it was the research of Joel Pools, when his experiences at the same circumstances and around the same time of the event that need to be remembered. We can understand that the appliance inhibits the action of the facial nerves. And as the facial nerves is inhibited, that this will activate the trigeminal nerves. And the trigeminal nerve is very important because it will control the swallowing network, but also the respiration centers by its sensory nucleus. And so the anoetic rehabilitation is only 15 minutes per day, does not require cerebral participation, does not disturb sleep. And moreover, the re-education, the rehabilitation in front of a TV will allow the limbic system to associate this moment as a reward and thus make easier the imprinting of a new pattern, and it will not interfere with any cortical information. Because we must speak about freak briefing, because it's impossible to change the swallowing if you have a bad buccal respiratory. And it's impossible to restore a nasal breathing if you have not restored a correct tongue posture in repo. And we must know that the newborn breathes through the nose, and at that moment the tongue completely filling the oral cavities. But if an obstacle prevents the passage of the air through the nose, the newborn begins to breathe through the mouth, and this activating a new meta-circuit. And when the children with breathing is normal, the oral facial muscle does not intervene. The lips are in contact without contraction of the orbicularis. And Usual and Guerrier were famous pediatrics, says many children have a lip incompetence, but they are not mouth breather because the soft palate tongue posture achieve a second closure system, and which will allow to create this posterior seal, which is the optimal chance to inhibit mouth breathing, and that could favored by the fact of the lips are relaxed. The trigeminal nerves control also, but for changing the nasal breathing, we must take care that there is no anatomical problem. And I used aerophonoscope from Professor Delaire. We can immediately show if there is an obstacle for nasal breathing. And so it's not necessary to go to the NT for each child, only if this test shows us a problem. And there is also the use of the olfactory bulb. And it's also very important because the olfactory areas are just among the oldest structure of the brain, and it is not well developed for human person. And so I very often used some exercise, recognition exercise. We can facilitate the restoration of a nasal breathing because the air does not smell anything. And if you ask the child to smell some perfume, vinegar, wine, and after close the eyes and recognize that this neuronal network will be very more efficient, and you know that the speed of information are much more faster by the olfactive system, but by the breathing system. The inhibition of the facial nerves allows this activation of a trigeminal, which allowed the dental occlusion. And remember when we spoke about sucking deglutition, we told that the mandibular is stabilized by the facial muscle. And it's very important that we can obtain the stabilization of the mandible. And when we stabilized the mandible by occlusion, the superior part of the tongue will be closer to the palate, and it will be much easy to swallow by a peristaltic movement of the tongue. The tongue will then fully fill the mouth with his eye posterior posture, and that's which will make mouth breathing, stimulated max breathing. And I spoke to you about changing of a swallowing program, changing of breathing program, and there is new information and a new way for neuronal networks to communicate, and we can call this connexionism. And it has been proved by if some learning have stimulated several brain areas and created several neuronal circuits. The activation of one of them will lead to the action of the others. We are dealing with a connexionist system. And it's very important to understand that it is not the rehabilitation of one praxis that must be taken care. Swallowing for us, for orthodontics, breathing for sleep medicine, the drainage of inner ear for ENT, speaking for speech therapist, but all of the oral factual practices to ensure a global and stable dynamic balance. Unfortunately, nature can help us if we respect its acquisition processes that are physiological. And we must go beyond the stage of aggregation, and we must reach the stage of automatization. The neuronal network that managing the overall practice will be involved by this system, and this role is assigned to the glial cells. And we very recently know that glial cells are 4 or 5 times more numerous than neurons, and essentially that glial cells has a role which is essential in neural. And how it occurs? We know that the neuronal network is a conversation between different neurons at the level of the synapse. But it's like a phone call, person-to-person transmission conversation. And around the synapse, the glial cells pick up the conversation and will broadcast this information to all the other neuronal circuits through gliotransmitters. And so all the circuits can take this information and says, oh, is it important and or is it not important for our use, and can we benefit from this information to improve our efficiency? It's the neuronal transmission is like a phone conversation. Glial transmission is like a radio, and it has been interesting to know that Anne and collaborators have injected human glials in the right brains, and they enhance their learning. So the glial cells are only for human, and it's very few developed in animals' brain. But I say, is it enough? And Marie-Vonne Fournier, who is a famous speech therapist, says that there is lots of relapse in re-education, this kind of re-education. And is it really a relapse, she asked. And she says, no, it's not a relapse, but we have not done sufficiently far to change not only the engramming, but to institute automatization. We must pay attention to the automatization of this function through the control of the lower brain by the practitioner, and then very often by the parents, and to ask to teach the patient to trigger the good icon to call the right programs. And, you know, it's like a computer. Imagine when you buy your computer, you have an icon to swallow. And 4 years after you buy it, you take the information that there is a new program to have a better efficiency. And so you print this new program. But if you continue to click to trigger the old program, you can have the good one, but you will not use it. And so it's very important to learn the child to trigger the good icon. And the primary swallowing icon is triggered by the activity of the facial nerves. My lips are contracted, my teeth are not touching each other. The icon of a secondary swallowing type, my lips are relaxed, my molars are in occlusion. and there is a dominant action of a trigeminal nerve, which will allow not only the molar occlusion, but also the protection of the tongue from being bitten due to the richness of the trigeminal nerve endings on the epithelial covering. And we can say that relaxed lips are the key point of our re-education. So how to encourage automatization? And the scientific question was resolved by Robert Bjork, University of UCLA, and he asked his students what is the more efficient program. And he proposed 4 programs with exercise, 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 and at the end the evaluation of the therapy, of a protocol. Another is exercise, 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 test before evaluation. And the last one was just 1 second of exercise, for instance, wearing froggy mouth, and test, 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 before evaluation. And test, test, test are what we ask the practitioner and then the parent to do. And Stehan confirmed that this approach, and he says dozens of scientific publications demonstrated its effectiveness, and it's called retrieval practice, and he is the most effective pedagogical strategies. And this strategy will also will be used in a game program managed by artificial intelligence, because it's generally only at the end of a game that you know whether if it's won or lost. And the trick that computer scientists has found consists of learning 2 things at the same time: acting and self-evaluation. This has changed our approach for the automatization and transferred this retrieval concept to automated the good practice. And the rewards of good patterns release some dopamine, and dopamine which reinforce the synapse, and the not good pattern will lead to the correction of a motor program by cerebellum. Under the orders of the premotor and motor cortex, the motor sequences will be managed by the circuits of the gray matters of the spinal cord and the tegmentum of the brainstem, that means alpha motor neuron. And it will be supervised by the ganglia of the cerebellum, which detects and corrects the difference between the movement performed and the expected movement, and the basal ganglia, which erase the wrong data and prepare the movement to come. The right circuits will be strengthened unconsciously by the release of dopamine. And so we can ask the parents to do this job, and they don't spend a lot of time. It just says enough free time. Oh, your lips are in a good position, and 3 times a day your lips are not in your good position. And very quickly there is this test that emphasize the automatization. And closer the child's age is near the age where this happens naturally, the faster will it be successful. And it's really much easier for the child and even for the patient to control his lips than to control the 17 muscles of the tongue. And as well, it's much easier to watch the lip of the children to say, oh, they are in good position, they are in bad position. This method will be much more efficient than spending our time correcting evil. And this will stimulate the cortical loops at the level of the cerebellum with one correct wrong gesture, and the other one refines the good sequences. The connexionism can be shown by the domino effect. And this connexionism permits us to have re-education of a very difficult control of certain networks, like the oropharynx network, which manage the posterior part of the deglutition. And when you control the lips, that will also stimulate the posture of the tongue. And when the posture of the tongue is correct, domino fall, and it will facilitate the restoration of nasal breathing, and so on and so on. Recently, neuroscientific discovery help us to have a sharper understanding of the importance of inhibition. And inhibition, what we want when we use froggy mouth, is to inhibit the development of an old program. The inhibition, now we know that Ledo says learning is not only the ability to produce a behavior that was unknown, but it's also an approach that inhibits the automatical mental processes. Change said learning is also eliminated. And there is a very interesting work that has been just published by some researcher of the Unigid Faculty of Medicine, and we can explain how the inhibition is important. But for your the daily practice, it's not very important to know the modification, the opening, the inhibitory of some network. But another man which was very important one, Daniel Kahneman, and Daniel Kahneman was also Nobel Prize. And he had a Nobel Prize in economy, and he has published a book which name was System 1, System 2, The Thinking Fast and Slow. And this book, he describes two ways to think. The first one is heuristic, approximated. This is the System 1. And in opposite, there is the System 2, which is analytically exact, but very much slower. And the System 1 dominates our thinking by cognitive and unconscious automatism that can be brought to light thanks to functional MRI studies. And the System 2 is a reflexive system that can oppose to some System 1 automatization, but with conscience and effort. And Olivier Houdet says, adds a System 3 that inhibits System 1, and the epicenter of this inhibition is located in the inferior frontal gyrus. Sucking swallowing program was established by anoetic pathways through the System 1. And the top-down re-education is done by the System 2. And so, if you have learned the good deglutition, you are in System too, but to put it in practice every day, to have this automatization, you must inhibit the system 1 program. Our froggy mouth approach, the modifications are in the system 1. It does not go for conscious effort, but instead by a new automatism inside the system 1. And only the notion of comfort will grant the priority to the new program. There is a good test, because in this connectionism is to understand the efficiency of the interaction with the speaking program and allow us to use a global test to access the success of the failing of re-education. And we must know that the coexistence of sucking and screams and chewing and spoken language seems to demonstrate the interweaving of a verbal and alimentary orality. And this correlation between dietaries and verbal orality is further reinforced by the fact that the anatomical pathways are analogous but used in the opposite direction. And you must ask the child to count from 1 to 16, but if the child are very young, from 1 to 10, and you must look where is the tongue. And if you see the tongue between the dental arches, you can be sure that the praxis is not automated. Because it's impossible to do two things at the same time with the same organ. And if the child articulated with his tongue, he will swallow saliva by contracting his lips. And if the lips modulate the sound, a simple contraction of the left muscle of the mandible will allow the dental occlusion and the peristaltic movement of the lingual dome. Yeah, you can see. When the child has, you can see the interposition, you must, during 1 week, to ask the child to count with the teeth closed. Just he can have impression and to understand the use of the lip. And next week, you will change this exercise and you will ask to speak normally, not with teeth closed, but to close the teeth during each number. And for instance, 1, 2, 3, 4, 5, 6, 7, and faster and faster. And on the beginning, when you go slowly, the tongue can go out the arcades and reintegrate the good position, not to be hurt by the occlusion. But if you go faster and faster, the tongue has no time to go out to enter, and the tongue will be found the good position inside in the dental arches, again by an anoetic stimulation. The important points through neuroscience. There is first the biochemical process that makes the imprints in the long time memory. And the use of a connectionism to modify all the orofacial praxis together and favor the automatization by retrieval practice and use the inhibition to prevent the use of the wrong praxis. I can show you some clinical result. Studies have been done in the University of Lille by the Dr. Cornu, and she tested 4 items which are always presented in the sucking deglutition problem. The labiochin contraction, and on the beginning of his work, 95% have a contraction of labial chin. And at the end, it was the T1 is 5 weeks and T2 was 10 weeks. And we can see when we reach 15% only of contraction of the labial fin at the end of experimentation. The swallowing rehabilitation on the the automatization on the beginning, 100% of the child are dysfunctional, and at the end, 16% of the child has a good imprinting and a good automatization. 20% have a good imprinting, but the automatization is not yet finished, and 20% have not changed his praxis. The tongue thrust also, you can see the absence of the tongue threads. We can see also that the interposition has disappeared for 80% of the children at the end of this experimentation. And the arch occlusion, and we say that the arch occlusion is very important to stabilize the mandible, and on the beginning there is just 8%, and at the end 82% of arches occlusion. There is also a publication in Italian. Fabio Scopa has learned by MRIs the area which is stimulated during this good practice and old practice. And it's very important that the re-educator don't ask the patient to put the tip of the tongue against the palate, because it is not naturally. And the good stimulation, and when you have the posterior part of the tongue which early enrich the palate. It's important because we can have, I will show you some clinical cases, and show Frogimov used with a complicated pathology. And this child has an hemoliphangioma, a lingual hemoliphangioma, so the tongue is very big. And we can understand that this child will develop a class 3, because all the tongue is in the lower mandible and stimulate the growth. And we learn this child with Frogimov to rise the bottom part of the tongue. And we can see that the amelioration of a class 3, because we have developed the upper maxilla. And some weeks later, we are quite in the good position. And at the end, we have corrected this class 3 only by changing the tongue posture. Another interesting case is a laryngeal kyst, and this was the son of our colleagues, and the mother says, oh, he was always the tongue out, and I can't understand how I can do. And I say, unfortunately, I don't think Frogimov will be efficient. But we give him the box of a Frogimov, he put through Frogimov, and immediately the tongue enter inside the mouth. And when we see it later, the tongue is always in a good position inside the mouth. And it was December, April, And another case which is very difficult also to re-educate it was a narcoleptic cataplexic patient. This girl was only concentrated on the game, video games, and so I said, don't listen everything at school. And it was very a great problem for the mother, and we can see his occlusion, and she has an open bite, very important. And I don't know why we can communicate it, maybe with by eyes. And she accepted to put Frogimorph once a day. We can see without any treatment the progress, and the open bite is corrected only by the re-education. Some few clinical results more current. April 5, April 17th. Another girl, she was 4 years old. She has an open bite. We just put Frogimorph. And she integrated the new program, and in May we take off the appliance. And when we continue to see, we can see the result, the progress continue even without the appliance, without Frogimorph. And we can see in October, just after wearing Frogimorph 2 weeks, the occlusion is correct. Another case, this girl was the sister of one of my patients. She had a long braces treatment, and 2 months after mechanical appliance has been taken off, reappeared an open bite, and just say, oh, okay, take it. Frogimorph in 15 minutes, and 2 months later we can see without any treatment the relapse is corrected. But also great because we can combine Frogimorph with pediatric appliance, and we can see it was the first slide, it was pacifier, but when we take off the pacifier, 3 months later you can see a change. But between 3 and 6 months there is no change, and so we could understand that the first step was to take off the pacifier, but the second was to learn the tongue how to correct correctly. And when we begin this re-education, the occlusion occurs spontaneously, and you can see there 3 years later. It's class 2, very important class 2, and we must not say, oh, it's too difficult, it's genetic, so we will chirurgical practice when he will be 15 or 16. We can stimulate the growth of the lower jaw, and you can see before 6 years old the overjet was completely corrected. And you can see from the beginning and at the end the modification of the lip posture. And this case is not a pediatric one, but we can understand that when you have functional treatment, you can undercorrect the anatomical deformation. And this girl was 8 years old. She has class 2 and open bite. We put a functional appliance, made the re-education, and we can see the progress in 4 months. The open bite is smaller, and at this stage the father says, oh, unfortunately we must go on the other side of the world, and I could not come before 1 year. And I said, oh, I think the reeducation is correct. Come back in 1 year. And when they come back after 1 year without any treatment, you can see the correction go on. It's much more better than when we stopped the treatment. And 2 years later, she come and we can see it's more and more better optimized. And 3 years later, without any intervention, we have a perfect result. So take care of your reeducation in all your orthodontic treatment. Pediatric orthodontics, adolescent therapeutic, surgical therapeutic. You must take care of the function if you want to have a good result. And I think Frogimorph can help you to obtain this result. Thank you very much for your attention.